Well, good morning. I'm Ed Shore, and on behalf of the Lucille Packard Foundation for Children's Health, I'm happy to welcome you to this webinar that's going to be discussing the increased flexibility around telehealth policies that were adopted in response to the COVID-19 pandemic. The webinar is based on a report on the policy flexibility that was prepared for the foundation by staff of the Health Management Associates, which is a national healthcare research and consulting firm. We hope you have read the report. Today, we will focus on the part of the report that addresses the changes in telehealth policies, and especially how those changes affected the care of children and youth with special healthcare needs. Preparation of the report was led by Sharon Silo-Carroll, who is a principal at HMA and who has over 30 years experience in healthcare policy research and analysis. Sharon is one of our speakers today. She is being joined by Kara Coleman, who is an attorney, a parent of a special needs child, and director of the public policy and advocacy for the national organization Family Voices. Following Kara will be Dr. Allison Kerfman. Dr. Kerfman is a pediatric emergency medicine physician and co-founder of Sprout, which is an international research network for pediatric telehealth research. And then for the perspective on state policy decision-making, our final speaker is Cheryl Roberts, also an attorney and a lead administrator for the Medicaid program in Virginia. Cheryl has an extensive experience in healthcare systems and insurance organizations. More detailed summaries of our speakers' experience is available on the Foundation's website. Telehealth services have been available for quite a long time, though their use has been severely restricted by a variety of factors, including slow acceptance by providers and patients, restrictive public policies that are affecting healthcare professional practice, and public and private payment policies. As you're no doubt aware, the pandemic seemed to erase many of these barriers and allowed many parts of the healthcare system to continue operating despite the dangers of face-to-face visits. As we approach the end of the pandemic, there is a need to take stock of the telehealth-related changes that have occurred and to determine two things. One, which of those changes should be retained? And two, what are the actions that are necessary to retain them? Today's speakers will address those questions as well as speculate on the long-term effects of telehealth on the quality of care and the health outcomes of children, especially children and youth with special healthcare needs. Let's begin with a brief overview of the report by Sharon Silo-Carroll.
Thank you, Ed. I'd like to quickly thank the Foundation for supporting this work, Ed Shore, Holly Henry, and Lee Nguyen for guidance. And I want to acknowledge my good colleague and co-author, Dr. Helen Duplessis in HMA's LA office. During the pandemic, particularly in the early months, closings or scaling back of clinic appointments, in-home and school-based therapies significantly undermined access to care for children and youth with special healthcare needs, especially those with medical complexities and those in special education programs. To promote access to care generally during the pandemic, federal and state governments created temporary policy flexibilities through a variety of legislative, regulatory, and administrative mechanisms. Emergency Section 1135 waivers, Medicaid and CHIP disaster relief, state plan amendments, Appendix Ks for home and community-based service waivers, executive orders, and other mechanisms. Most of the flexibilities authorized by the federal government will remain in place until the end of the national public health emergency, which was expected to go through this calendar year, but there have been some rumors about moving that up to October. And states are starting to end their emergency policies earlier in coming months. Next slide. The Lucille Packard Foundation for Children's Health supported HMA to examine two key questions: which temporary policy flexibilities affected children and youth with special health care needs, their families, and their providers, and what policies should be continued after the public health emergency periods end. Next slide. So we conducted a federal and policy review of changes during the pandemic. And last fall and this past winter, we interviewed pediatric clinicians, advocates for children and youth with special healthcare needs, researchers, maternal and child health program leaders, and other public and private stakeholders about what they and the families they serve have been experiencing on the front lines. Next slide. A universal response that we got was that policies expanding the use of telehealth, generally defined as the exchange of medical information from one site to another through electronic communication to improve a patient's health, have significantly impacted and been largely beneficial to children and youth with special healthcare needs and their families. Our report describes the mechanisms used to create the flexibilities, and it also identifies other important temporary policy changes like increasing the federal Medicaid match to states, relaxing Medicaid eligibility and renewal requirements, provider participation rules, scope of practice, prior authorization requirements, and expanding states' ability to pay family caregivers. The report also highlights how the school closures, unemployment, isolation, social drivers of health put tremendous strains and affected the mental health of children and youth with special healthcare needs and their caregivers. But today we're going to focus on telehealth. Next slide. It is important to note that unlike Medicare policies, the changes to Medicaid programs during the pandemic, for the most part, have varied by state. Some policies more commonly adopted than others. Most importantly, we saw expanded reimbursement for services provided through telehealth in additional locations, including urban areas. New flexibility in both the originating site, that is where the patient sits, and the distant site where the provider is working, to include patients and providers' homes. Reimbursement for telehealth expanded for additional services like care coordination, well child, and EPSDT visits, pediatric behavioral therapy. In fact, telehealth was more likely to be used for behavioral than for physical conditions during the pandemic. Reimbursement expanded to additional technologies, including audio-only devices like telephones. It expanded to different additional types of providers who are able to offer telehealth, including physical therapists, occupational therapists, out-of-state providers, including subspecialists, particularly important for children with special healthcare needs. Reimbursement also expanded to additional health services provided through school-based telehealth. 16 states issued guidelines to providers to allow for telehealth or remote care delivery for early childhood intervention services. Another essential policy flexibility to promote telehealth was to pay the same amount for a service provided through telehealth versus in-person, or payment parity. At the federal level, we saw relaxed enforcement of HIPAA privacy rules, which enabled telehealth through additional technologies like video chats, Zoom, and Skype. Next slide. As telehealth increased rapidly during the pandemic, stakeholders also emphasized to us how greater use of telehealth had significant advantages, particularly for children and youth with special healthcare needs. For example, less need to transport the child, their equipment, and in many cases, siblings to appointments. It also reduced the risk of exposing already high-risk children to both COVID-19 and other infections by having to go out to clinics. There was better access to specialized services for children and youth with special healthcare needs that which was especially helpful for families in rural areas or those requiring services across state lines. Stakeholders also saw a rise in telehealth addressing behavioral health needs, helping to address some additional mental health challenges, although not nearly enough, not as much as what was really needed. Through all of these benefits, there was potential to reduce disparities and address workforce challenges and shortages, especially pediatric specialists and subspecialists. Next slide. But these expansions in telehealth also highlighted disparities, as many low-income and rural families faced language barriers, or didn't have the broadband access or equipment or technologies required for telehealth, or they lacked safe locations to conduct visits in private, or they lacked guidance on how to request or use telehealth. And there's been inconsistency in the degree that states, health systems, and providers have adopted the flexibilities to make telehealth more available, even if the regulations and the policies made those more feasible. Next slide. We created briefs with recommendations for federal, state, government, public health, maternal and child health, Medicaid health plans, and the medical community that are available on the Foundation's and HMA's website regarding those policies that we felt important to continue after the public health emergency. In the interest of time, I'll just cite a few examples. First, telehealth should be considered another routine modality for providing appropriate services. That is, not as a separate service with separate rules, although guidance is important to ensure quality and accessibility. CMS and state Medicaid programs should target funding for telehealth equipment, training for families, providers, and schools, extend broadband coverage to ensure equitable access across all communities, especially in low-income and rural areas, and also ensure interpretation services are available during telehealth visits. CMS and state Medicaid programs should continue beyond the public health emergency period. Policies like payment parity, audio-only telehealth, PT and OT, care coordination, originating in distant site flexibility, easing of out-of-state licensing restrictions for telehealth providers. I will note that the Consolidated Appropriations Act passed in December and a growing list of state legislation and executive orders are making permanent certain flexibilities around telehealth, particularly for behavioral health services under Medicare and under Medicaid. Next slide, please. States and Medicaid health plans should be creative about encouraging and incentivizing telehealth. For example, incorporating telehealth into medical home models for children and value-based payment models, piloting like texting as a telehealth modality, especially for young people who may not have privacy for telephone calls. They should consider reimbursing telehealth provided by specialized practitioners or assistants who support children with medical complexities in schools and child care settings. Next slide. Maternal and child health, public health, Title V programs should expand outreach and training on telehealth for families of children and youth with special healthcare needs through family support organizations. They should include family members and advocates in emergency preparedness planning to make sure that the needs of this group are incorporated into future emergencies. Should explore developing registries of technology-dependent children and youth for first responders that make action plan, for example, making action plans and advanced directives available to EMT staff and other first responders. And they should expand and provide care coordination support whenever possible. Next slide. The pediatric community and professional associations, health systems should develop clinical guidelines that identify appropriate use for telehealth for special services and conditions among children and youth with special healthcare needs. Explore how well child visits through telehealth can be reimbursed and monitored for quality. And document should be used to enhance interdisciplinary team-based care, which is especially important for children and youth with special healthcare needs and can actually reduce the communication and coordination burden on caregivers. There should be greater resident training programs that require comprehensive instruction for new physicians and also existing clinical staff in conducting telehealth visits. They should also have a focus on the importance of cultural competence and concordance. Next slide. Now that time has passed, the federal government should fund and coordinate with states, practitioners, and researchers to thoroughly evaluate and document the impact of the temporary policy flexibilities on a range of access, utilization, developmental outcomes for children and youth with special healthcare needs and other at-risk populations. And as we further document which policies improved access and outcomes for specific conditions or subpopulations, we should let the data drive policy going forward. I'm happy to share more about the report and answer questions later in the webinar or anytime after the webinar. For now, I'm going to shift over to my speaker, Kara Coleman.
Thanks, Sharon. I'd like to start off just my few thoughts and comments that I wanted to share by maybe asking you guys to close your eyes for a second. Hopefully everyone's seen somebody's version of a care map. The original care map was hand-drawn by Kristen Lind from Boston Children's Hospital, in which you have Kristen and her family at the center, and then just this massive map of people and things and all of the ecosystems that involved in the care of her child. And then take that picture in your mind's eye and whoop, move everything that populates in that ecosystem outside of a sphere. And the family's in the center. That's what many of us, all of us, experienced in some way during the pandemic, but heightened, as you well know, for all of the kids with special healthcare needs in their family. And, not to over or under exaggerate the power of telehealth, that, picture an old loopy phone cord that is connecting those families very critically to health services, PT, OT, speech, language, really critical things through telehealth. And the reason I wanted to draw us back to that and have us remember is because much of the discussion moves right now to, as Sharon already said, perhaps the public health emergency will extend to the end of the year, but maybe it's looking like it's forward. But moving forward, for kids with special health care needs, we really have to stop and remember that those under 12 who cannot yet be vaccinated are really still in danger. And so those families remain very isolated. And so the power of this telehealth remains for those in particular, but for all kids with special health care needs, especially as we look at sort of the tail of this public health emergency extending out. It's long, and the needs of our kids with special health care needs are not one size fits all, they're unique. And so how do we take this amazing tool of telehealth that, as Ed referenced, it's not new, but all the barriers and access to it, were gone overnight. How do we keep this around and tailor it to the unique needs of every child? I mean, is that possible? Sure feels like it's not, but it felt like this kind of access to telehealth wasn't possible, however many, a year and a half ago, right? And here we are. And telehealth, I guess, in a way, in terms of accessibility for people with disabilities, for children, youth with special healthcare needs and disabilities, is like a curb cutout. It opens the world. But, going back to, the wonderful terminology that Sharon and her team use in this, what should we look at? Keeping, modifying, and discarding. And so one of my main real points that I really wanted to start with is, let's keep everything, because how do we know? Do we yet know? And I see there's already a question about, are there studies? There's not enough yet, right? We've got to keep this around for our kids, or else we have to know this, right? That we will create more disparities. Because we also know that our kids with special health care needs have less access to medical home, less access to a well-functioning system of care, and especially those Black and brown SHIN. And so if we remove these telehealth overnight, we'll create more disparities, because as Sharon referenced earlier too, the power of this tool of telehealth to help those in geographically remote regions, or even, my concept of what's geographically remote definitely changed when telehealth was put on everything, because we began to look at remoteness, quote unquote, in terms of connectivity, right? And who has access to broadband? And we saw through our Family Voices network that many of the staff of the Family to Family Health Information Centers weren't even that remote or rural or frontier, and they had no access. The same as the families they served. And so this is really critical to keep around. And then let's use that wonderful word of modify. It's one of the greatest gifts the Americans with Disabilities Act gave, is accommodation. And how do we do this? So my three other points really center around, one of the key reasons that we need to keep telehealth around too is that we need to get to the active part, that telehealth is not just a reaction or a substitute for in-person care, but that we expand it to be, in-person practice is focused around family-centered care, the active approach to using these core concepts of family-centered care: dignity, respect, information sharing, participation, and collaboration. We struggle with that sometimes in person. So how can we get that in telehealth? There's lots of stories of families that didn't have the broadband access or the devices, hence the digital divide, but also those many who didn't get access to interpretation services and other accommodations for vision and hearing to be able to use telehealth. And so we need to keep this around to be able to expand to that family-centered basic dignity, respect, information sharing, and all that, but also go further. How do we use these tools of shared decision-making to decide, how do we use and keep telehealth for this child? Is it right for every child? No, that's one thing we learned, is that it's not a modality that maybe works for everyone, assuming they have the basic digital access. For some kids with special healthcare needs and disabilities, they were not able to engage on a screen for school, for a doctor's visit, for therapy, for anything. And so, it gets me back to that sort of need of, we've got to keep it around and work together to be able to figure out, how do we use this in real life? How do we take care and look at and listen? What are the cultural adaptations and responsiveness we need in terms of this? What are the linguistic? How do we know what's best for each child and their specific healthcare needs and other needs? And looking sort of to the future, I know I'm running up on my time, but just a few things for the future is, Sharon was referencing at the end in some of her recommendations about training and buckets of training. And one thing I want to comment on that is, yes, families need a lot more training on how to engage. Some families are stuck with 10 different ways to log on to telehealth. That is a lot. How can we make it more systematic? And how can we learn together, office staff, providers, residents, whoever, how hard it is, and figure out how to talk through and walk through and work through together. So I think the training needs to be for families, but it also needs to be by families, family as faculty and teaching. How does telehealth really work? What do you do when you have cultural considerations, multi-generational considerations at home, linguistic, other accommodations? How does that work in the home, and how does it work in office, and how do we come together to make things better? And how do we use this technology to bridge and bring humanism to everything? And the last point I wanted to make is, just really one of my favorite parts of this wonderful report that the foundation and HME created is that, we need to look at telehealth now as, thank goodness the barriers were dropped, but how do we make this a permanent structure, a permanent part of the model of care of kids with special healthcare needs, that families can choose to access in partnership with their providers, their health system, to make sure that they're reaching each child's health needs, their care coordination needs, the communication needs of this interprofessional team that doesn't somehow get together, and mom as coordinator in chief and communicator in chief is stuck in the middle doing. How can we keep this tool here permanently and decide together how to use it as a lever to take care of our kids and get rid of these doggone disparities? And so with that, I will pass it to Allison Kirkman.
All right, thank you so much. I'm very happy to be here today. So I'm a pediatric emergency physician, and children with special healthcare needs have a really special place in my heart. I have been managing a program for these high needs children through telehealth for the past several years here at Mercy in St. Louis. And, I might actually just tell a couple of quick stories. That's where a lot of my conversation went with the authors of this report when they were interviewing me initially. But there's three main components of what we're always trying to improve in healthcare. So it's the access to care, quality of care, and cost of care. And children with special healthcare needs really have a very different set of requirements that the very broken healthcare system really does not tend to serve them well. And so I think about one of the first patients that we cared for in our virtual program, and she was 16. She had a lot of specialists. Her parents were working like crazy trying to alternate their shifts so that someone could always be home to care for her. And when they went to their 9 or 10 different doctor's appointments, it was hard to keep it straight who they were supposed to be asking questions to. And through our telehealth program, it really gave us a chance to be present in their home in a less stressful situation. They didn't have to travel, and we had a lot of continual care visits with them, and we were able to pick up on some gaps in care that maybe weren't discovered during their traditional healthcare visits. For instance, she had grown and had never had a lift at home. And so her dad was picking her up every time they needed to move her, and they didn't have the actual equipment they needed to care for her. But they didn't really even know which specialist to ask that question to. And it seems that by kind of filling those gaps and providing this more continual care in their home, a lot of these questions that, I mean, it's so hard to remember all the questions about all the different things their child may need. We were actually able to proactively identify those things. And another story I share is a little guy that I actually saw for the first time in the emergency department. And his parents rushed him in, carrying him, and he looked like he was about to die. He was in shock, and we all jumped to resuscitate him. And the mom was trying very desperately to show me a video on her phone. She wanted to show me what he was at baseline and what he looked like at baseline and how interactive he was, so that I wouldn't give up on him. And I feel that the relationship with families at the center of this issue is so important. Now, these parents feel like they have to advocate for their kids because they know that no one knows them the way that they do. And this very fragmented system that they access, nobody necessarily knows what their child's needs are comprehensively. And so through the program that we had, we were able to really take a very patient-centered focus. And it's funny to me because I always felt like what we were doing wasn't really all that transformative. I mean, my 2-year-old knew how to FaceTime and my 87-year-old grandma knows how to FaceTime. So the actual technology is really not that hard to comprehend, but the further along we got, the more we realized that there are just insurmountable barriers to this sort of program. We had a very, very patient-centered approach and almost just completely designed from scratch what the system should look like for children with special healthcare needs, and created that with some funding we had for an innovation project. But unfortunately, that sort of care coordination and really continual care in the home, which had really profound financial and quality of life implications for these children, just was not reimbursable in the current state of healthcare. And we felt like we were really just pushing up against a brick wall, that it was very, very hard to encourage adoption. And I guess I was kind of surprised by that. But then when COVID hit, all of a sudden it was like everything changed. It was like everyone who was against doing virtual visits all of a sudden was very motivated to do them. And all of a sudden we were able to change the way we were getting reimbursed for visits. And so one of the key points I think that we've learned is that you actually can truly improve access to care, especially for children with medical complexity or special healthcare needs, using technology. And there is a lot of, policy work and reimbursement that will need to continue to be available for us to be able to deliver these services, because it will not happen it's not compensated, because there's no way to create a sustainable program or solution to serve these children without that reimbursement. I do have to say that at the beginning of COVID, we actually had to stop our program because it was all funded with an innovation budget that was not available during COVID. And so we're working really hard with Missouri Medicaid to try to see what we can do to continue to provide kind of this new type of service for children. And I think the remote patient monitoring codes that are being developed for reimbursement will be a great way to do that. But as we improve access to care, and as we hope to really expand the way that these children can connect with their healthcare teams, we have to have it top of mind that we are not furthering the well-known healthcare disparities that exist in our very broken system. We have to make sure that we are pushing policymakers to account for the fact that there is this phenomenon known as the digital divide. Not everyone has access to broadband internet or a personal device or even a medical home. And we have to address those things in order to really truly make this technology improve access in an equitable way. And the last thing I'm going to say, as far as the cost of care, is definitely something that can be truly effective in these children. We saw huge cost savings for Medicaid in the population that we cared for, because we reduced their emergency department visits by 50% and their hospitalizations by 25% in just 1 year. And so by providing that kind of hand-holding, coordinated care with a team that knows you and knows your child and your child's needs, that was able to truly impact cost of care. And then finally, quality of care. We're working on an economic evaluation of the program to determine, if you take into account all of the quality of life measures these children have when they're able to be cared for in their home, when they're able to not have to travel with their ventilator to go to see a provider or go to the emergency department. The days at home, we use days at home as a quality metric. There's a lot of things that we can measure. And as we're doing this work, we need to make sure that we are assessing how we measure our outcomes. And that's part of why we started a multi-center research network on telehealth to make sure that we are distributing frameworks for metrics that should be measured in telehealth projects, and really considering what more agile ways of doing research can we produce that will get the evidence base for some of these things that our policymakers need to see, and that we need to see in implementation and discussion of best practices. So with that, I'm looking at my timer to make sure I'm sorry, I went over by a minute, but I'll pass this on to the next speaker, and thank you again for having me.
Hi, good afternoon. I'm going to give you a look at the world from the Medicaid scope. Obviously, Medicaid covers children. That is obviously a fact. In fact, Medicaid covers about 37 million children in the United States. But Medicaid agencies are many things. We are obviously a payer. We are obviously involved in the policy. And then because of managed care, we've become contract managers and contract negotiators. And so as we're looking at the whole entire system, we're able to look at it almost like holding up a prism, that we have different ways of looking at it. The pandemic obviously came through unexpectedly, and it affected us both federally and on the state level. On the federal side, there was lots and lots and lots of flexibility that we are grateful for. Obviously, the biggest one was the maintenance of effort, which was critical, particularly in our state, which has the Medicaid expansion. Hundreds of thousands of people were able to keep their eligibility during this crisis, and we are grateful for that. But also it gave us flexibility in an administration, which we took, and it also gave us additional funding flows with the CARES Fund, and we just basically had the opportunity in terms of opportunity to tackle the challenges aggressively, and we took them. I mean, I'm talking not about just the state of Virginia, because I'm not going to just do that. I'm saying all across the board. We saw bipartisan groups working together to tackle each and every issue, sharing innovation and flexibilities so that we could get to the most neediest people quickly. And then on top of this, from a perspective for children, we had some other challenges. Okay, one, the issue of no schools. Schools provide both two things, obviously school-based services, but also a check on children. Having teachers and school systems to have that and not having that ability was a problem. Clearly, the ability not to be able to go into the home, either do assessments, but also to do home visiting in many, many situations. And then the increased need for behavioral health, and then the ability to reach those children. All of those were challenges. On a good note, telehealth was an answer quickly that we were able to adjust to. I'm laughing about that because for years and years and years, we've had telehealth advocates. It wasn't like it was new, as everyone has said. And then all of a sudden, in 2 days, the whole nation says, yes, you could do telehealth however you want. That's a challenge in itself. How do you do the definitions, the criteria? How do you fund it? In our case, we decided to make it in parity for in-person visit. What do you say to providers? What do you say to your plans? You try to do that very, very quickly. Again, we're looking in terms of days and hours, not months, where normally it would take on average Medicaid agency anywhere between 30 to 90 days to do a new policy. We were doing it in 30 hours. And so everything was moving very, very quickly. The good news is that it was clearly accepted, particularly in our behavioral health. We saw that providers were able to make those exceptions very quickly. We're very grateful, and providers all around as we were working forward is. And our General Assembly, in our case, got involved, and they got involved in remote patient monitoring, ironically, Allison. So everyone was engaged on how to do this and how to do it well. This month, on June 30th, my governor, Governor Northam, lifted the state of an emergency. And that put us actually in an emergency to figure out, what do you keep and what do you let go? And some things you have to figure out how to do that kind of a balancing act. Okay, so the first thing you think about as you're trying to make those choices is, what is good for the member? Obviously, we are conscious that in our case in Medicaid, not all of our families are vaccinated. We are now adding a new group, which is younger adults and younger teenagers. So we have those kinds of questions. What's good for the system? We're talking about both providers, health systems, the whole system and how it's working. And then to be honest, we have to think about the budget. The budget criteria plays a role too. And so we think some things stay. Without question, there's no question. Telehealth is staying in Virginia. No questions asked. We know that's going to be there. We embrace it now. It's going to become part of our day-to-day. Some things we want to see. We do want to see home visiting again. We're asking for people to go back into the home, particularly for assessments, particularly in cases where we can. We're asking people to go back. We want to get ready for back to school. Okay, and so we're making a big push. You'll see in the Commonwealth where we're starting to say, in August, you're going back to school. We want you engaged. We want you involved. What can we do to support that? We've learned now that we have to pay caregivers more in all sorts of ways. And so we're paying for sick leave. We've added money to personal care. We are working on that. We understand the value. I think if nothing else, we've learned some hard lessons about the people who actually care and take care of our children. Some things we're going to, as people said, go back in terms of doing things. Revalidation of providers, program integrity issues, some of those. But not again. We've learned our lesson. Not in 20 hours. We're giving people 60 to 90 days to get back into that groove. But the issue is that we do think some of those things are good for the system. What do I see for telehealth in the future? Okay. One, again, someone had told me 2 years ago that I would say, oh, we used to say telehealth could do it for the rural areas and 1 or 2 services. Now I ask the question, what can't be done in telehealth? 2 different ways, 2 different looks at the game. We're doing policy. We have to do criteria. We do have some questions we got to ask ourselves. I do understand HMA has had some suggestions. Do we think texting is really a visit? How many visits do we think should be telehealth? What kind of training do we believe people should have? Do we think, what should we tell families? All those kinds of questions. Should there be limits? Okay. Should there be some criteria? And I hate to ask this, are we going to see fraud and abuse? We've had stories where we've heard that providers have called all of their patients and spoke to them for 2 minutes and charged us all for a full visit. Is that what we want? Okay, maybe yes, maybe not. But the question is, those things will have to be discussed as we go forward. What we can say is we do know, and this part is this much, is that the crisis did many, many, many bad things. I wouldn't want it ever to see that again. But one of the good things was telehealth. It made us open our eyes and say that something that we should have done. Here we are, a nation that's depending on telephones, has been doing that in iPhones, and then didn't want to believe that we could do telehealth. I mean, this is actually ludicrous, and I'm glad we're here. And then my last comment is, if I don't say it again, I do want to thank every provider and every advocate and caregiver that took care of these kids. It was a horrible situation, and we saw heroics that we could not have believed. And from all the Medicaid agencies, I do want to thank you all for doing what you have done. Ed, I'm giving it back to you.
Thank you, Cheryl. And thank all the speakers. We've gotten a lot of good questions. I hope we have time to answer most of them. Let me go back to Cheryl, just since you just finished. You raised an issue that some of the listeners have also raised about the balance between budgets and services. How does your department make that determination? How do you decide? I mean, you raised a lot of issues that you're going to have to decide. How are you going to go about deciding them?
Some of them are decided by our General Assembly and the governor. I mean, some of them will be decided. For example, is when we did patient monitoring, that was done in our General Assembly session. Like what will we do and how we're going to cover it is actually done there. For each of these types of things, our chief medical officer is very much involved. He's talking obviously to the health plan's chief medical officers as we try to figure out what's the right modalities. And then the question is, we cost it out and we decide on what we think that's going to work. In many of these cases, it's funny, we're looking at other states. And I think NADMID plays a big role here because they actually have us together to talk some of these things out. But I don't know if we have a final answer on anything except that we've all agreed that we're going to keep it. That part is the thing. No, and that's a big deal. I'm learning more and more now. And as you know, Ed, that's a big deal for us to decide that we did like what we saw in behavioral health. We did like what we saw in terms of care. We do want the home visits for the assessment again, but we do understand that it can be a good alternative for many, many, many people. And we hope that particularly in our rural areas, and now we are finding in some of our urban areas, is a good answer. So the other one we're gonna have to talk about is evaluation. To be honest, probably in the next 6 to 8 months, we'll probably want to evaluate what actually did happen. Having someone actually go in, look at some of the records to actually see what happened. That will help us a little bit too as we move forward. To start to say, what was the patient's reaction? Did they enjoy this? What did it happen? Were they able to assess issues? And then talking to the provider community, because the provider community is going to play a major role in what kind of access and referral patterns that they want to see.
Great. Let me follow up on your last comment and ask Sharon, when you were doing the interviews, what was the difference between the opinions of the providers and the families, or what were their general takes on having this available to them?
Mm-hmm. I would say that just about all of the clinicians that we spoke with were very much aware of both the advantages of telehealth, but also the challenges that the families themselves were facing. Very much aware of the digital divide and the fact that certain families were just not able to access telehealth services. So their focus, the practitioners certainly emphasized the importance of payment parity, probably more so than the family side. But I would say that their general responses and attitudes were very similar in both cases, pointing out that telehealth works for some families, but not others. It's a very individualistic thing. So therefore, stressing the importance of both expanding the ability for families and practitioners to have what they need, the technologies and the training, but also allow the families to work with their individual practitioners to choose, to decide what works best for them. So I would say that was really, similar across both the practitioners and the family advocate side.
Great. Kara, would you like to chime in from a family perspective on what works, what doesn't? What's some of the family take on how this has affected them and their care?
Yeah. And even just listening to Sharon's answer there in the discussion, the importance of payment parity, I think that actually families recognize it, but they don't use those words, right? And they're going to character, this is the blessing and the curse of how we all communicate in these sort of parallel worlds, that families are very able to explain what types of access, whether it's just texting with their providers or audio only, and what works how and why for their given situation, their access, their family, their child's needs, but they talk about it in really different ways. And so it does line up, it takes that interpretation like this report does of lining up, and this is about payment parity. But coming back, and for families, it is, as Sharon really just described, for many, there's so many stories of families, and there's some even in the chat, of the connection that happened between patients and providers of all kinds. I remember quite a few that were able to access care coordination in a way they weren't able to before, and hearing from care coordinators and families alike, like, I had no idea this is actually what was needed. And somehow that didn't come to fruition in an in-person conversation the way that it did through telehealth, because people were home and had time, and the needs were heightened or looked at through different lenses and stuff. And so it was wonderful to have that telehealth. But, also, as I sort of mentioned, there was many for which the screen, even though everyone knows how to access it in some way, many don't, and many just can't relate. And so how do we make the accommodations in other ways to make sure? And really the answer again is, I think one of the big things is that somehow telehealth is this bridge, a technology that bridges the humanism. Like, how do we make this shared decision-making and family-centered care come to fruition? It's through these conversations together, either with providers and families, or, a few people had that access to, 10 different providers were able to get on the phone at the same time and come up with a plan together. That is a game changer for families that have such a fragmented system of care that Allison, really described. So that's just a few other comments, I guess.
Thank you. It sounds like we need to have a pretty broad array of telehealth resources available so that they can be personalized for the specific needs and resources of each of those families. Let me throw out a broad question to all of you. You can take it in turn. Of the various policy changes you've seen, which are the most important, do you think, to maintain? And why would you say that? Allison, you want to start with that?
Sure. I think the two that probably, you said one, but I'm saying two. The two that made the greatest impact in adoption were the payment parity, which in normal times is a state by state thing. So in certain states, they already had payment parity for telehealth. But when there was payment parity across the board, you saw a huge increase in adoption and then expansion of payment for additional services. I think that the whole idea that we have to take a very personalized approach is more amenable to new and different ways of paying for services. So some kids may benefit from certain services in the home virtually, whereas others may prefer to do that in person. I mean, the behavioral health aspects are a good example. I see a lot of teenagers in the emergency department, and some of them say that are there for mental health concerns, and some of them say that, you know, being able to connect via telehealth was actually a way for them to feel more comfortable and open up. And others said it felt really impersonal and they can't do Zoom therapy and they've gotten a lot worse if that was the only thing that was offered. So I think that the idea of taking a personalized approach to each patient is important. But from a policy standpoint, I think the payment parity and expansion of payment for additional services were the two that made the biggest.
Okay, Cheryl, what would you say? Which, from your perspective, which have been the most important policy changes you've put in place?
Obviously, payment parity, believe it or not, that was a big discussion. So I will tell you that was a discussion point. And not limiting to a particular set of services. Again, taking something that for us as administrators, beginning to ask the question, what can't be done versus what can be done. You see, taking that, assuming everything can be done was probably the biggest adjustment. For years, as you know, people did talk to us about telehealth, and we could tell you 90 reasons why that wasn't a good idea. And here now we're going the complete opposite. Once you have this big concern about what's happening in the house and you're desperate for people to get into that house by phone, in any means. So it's interesting to change it. Going forward, I'm going to say it's member training. Actually getting a member to understand what to do for that call, to be prepared, giving out information, being candid, so that the call can be valuable. I think that's going to be the next big hurrah to try to actually move that to be a permanent service.
Great. Sharon, I'll ask you the same question, but also we had a question that was quite specific, and that was that as long as states are, the question was, is it true that as long as states are having parity in payment, that they need not change their state plan to maintain the new policies?
Right now, I do not believe we had to do that. I can double check that, but I don't believe we had to change anything in our state plan. But I do believe that, as people are asking the question, is as we develop more and more intricate criteria, and I know our chief medical officer is working on that, that will probably decide on going forward what we will do. You see what I mean? Because right now we just opened everything up. Even right now, and we also now are speaking together with the plans and the groups and asking the question, you know, what is the answer long term? And also, to be honest, looking at the commercial market too. I mean, the commercial and exchange market, in many ways, this is an industry change. This is not going to be just a Medicaid change. It's an industry change.
Right. Kara, do you have a thought on which of the changes you think are the most important?
Well, since I can't select keeping all those Appendix K flexibilities as my answer, I will pick one. And I really think it has to do with site. You know, thinking about, we often say, you know, buzzwords of meet families where they're at. This change to be able to have home as originating site, you know, is a game changer for families in many respects, you know, which we've detailed of, you know, how it's so hard sometimes to get out of the house for so many different visits, and it allows you to schedule. and gives flexibility to be a whole family unit and well-being and quality of life and health, outcomes and stuff. But the other is, just the flexibility, not just in home as originating site, but allowing other originating sites. There's lots of different, I'm remembering hearing from our family to family health information centers in West Virginia and New Mexico and the Navajo Nation, and allowing another site. Some families don't have that access in their own home site. So going to some sort of hub where they can then connect up that is maybe only an hour away versus connecting and having to drive to the specialist 3 hours away. So that site becomes and creates much more flexibility and accessibility for families.
Great. Sharon, put you on the spot. You've looked at a lot of states in this. Which of the states do you think have done the best with this, and why would you say that?
Let's see. Not only did you put me on the spot, but we have one of the state representatives right here with us.
Who's done fantastically work.
So I'd love to put Virginia first. And I mean, I think because we were looking at so many different pieces and looking really more at total numbers of states that had passed payment parity or had guidance or executive orders for this or that. Honestly, I don't know that right now I could pull one state out. I would have to think about.
Let me rephrase it. What are the characteristics of the states that were doing well with this?
Clearly, states that were already doing, had a lot of flexibilities and were encouraging telehealth before the pandemic. Clearly, they were in a much better place to expand even further, as the flexibilities became available. Those states that were much, farther behind, had to deal with getting providers on board and, getting families, to at least know about what was available. So I think and the same was true with health systems. Those that were already, doing telehealth before, were able to just easily slide right in and expand even further. Whereas those, practices and health systems that were not really doing telehealth before had a much harder time because they just they were starting from a much, a place where they had a lot farther to go.
Good. So I hope the audience members have read the report. If not, a link to it is in the chat box. We will be making the slides and a recording of this session available. The report included a lot of really good recommendations. And so I'd like to ask Sharon and the others who'd like to chime in, how do we best use those recommendations? How do we use the report to try to get those recommendations adopted as we go forward? Sharon, you want to start?
Sure. So, in addition to the foundation and HMA working to disseminate this information to all different stakeholders, I think just folks that are on this webinar, could take a closer look at those recommendations, bring them to your colleagues and your professional associations and the leadership of your organizations. And then each of those organizations and write to, the policymakers in your state. But I think mostly, going through the different types of stakeholders, family advocates, pediatric professional associations, each has their own voice to promote new policies. And, I think that if it swells up across all different stakeholders, it might make the most impact. But I'd love to hear from others.
Any final comments from others?
I just say that I think really what Sharon is saying in there, to use a buzzword, that's around DC right now, is infrastructure. And Sharon's sort of referencing that in every state, there's some sort of different infrastructure of a family to family health information center, parent to parent, chapter. Everybody has different names. There's AAP chapters. Of course, there's Medicaid. There's all of, the different players in your state. And how do we come together to figure out how to take these recommendations and make standards and keep them for our kids and families, and so that they work and can be paid for in the future, but using that infrastructure that's already there.
Well, we've run out of time, unfortunately, and we have many more questions, which we can hopefully answer directly from the speakers to the people who've asked the questions. I assume the foundation has a mechanism to make those responses available to you. So I just want to thank our speakers, who were fantastic, bring a lot of expertise. I had lots more questions I could have asked every one of them. So thank you all for participating, and I want to thank the audience for listening in. And please take these recommendations, take them to your family organizations, your Medicaid programs, your legislatures, and see if you can keep telehealth alive and making the impact that it clearly has the potential to achieve. So thank you very much.